Hi guys, let us continue with meningitis. In this section, we are discussing the treatment of meningitis, especially the bacterial meningitis, since the infection with bacteria is more severe form than other causative organisms. So, the acute bacterial meningitis is a medical emergency and it requires prompt recognition and antibiotic therapy. This medical emergency almost universally requires hospitalization. It is frequently fatal even with appropriate treatment. And if we left untreated, death may occur in a matter of hours. Now, coming to the goals of treatment, let us take a look at the aims of the treatment. What are we going to achieve by the institution of the antimicrobials? The most important and the first aim is to eradicate the infection with amelioration of the signs and symptoms. So, we can eradicate the causative organisms and we can improve the patient signs and symptoms. And the second one is preventing morbidity and mortality. Before only we discussed that if treatment delays, it may worsen the patient's condition. So, as soon as possible, we have to institute the antimicrobials. Third one is the initiating appropriate antimicrobials. When choosing antimicrobials, a number of factors must be considered. First one is the antibiotic selected must penetrate adequately into the CSF. Second one is the regimen chosen must have potent activity against suspected or non-pathogens, and also they should exert a bactericidal effect. Okay. And the next one is providing a supportive care. Depending upon patient's condition or signs and symptoms, we have to administer fluids, electrolytes, antibiotics, analgesics, and other supportive measures which are very important to manage the meningeal infection. And the last one is the preventing disease through timely introduction of vaccine and chemoprophylaxis. Once the patient brought to hospital, we have to analyze the patient's attenders and take into consideration that patient's all possible close contact so that we can avoid the spreading of the infection because it easily spreads by close contacts. Immunization is the most effective way of preventing the bacterial meningitis. So, this is achieved by the immunization with vaccines, right? So there are monovalent or polyvalent vaccines. They help to boost our immune system, such as unconjugated polysaccharide vaccines against Neisseria meningitidis, then conjugated tetravalent ACWY meningococcal vaccine against ACW135 and Y meningococcal subtypes. Now, chemoprophylaxis, they should be given to close contacts depending upon the causative organism, and possible drugs that are given as chemoprophylaxis include rifampin, ceftriaxone, ciprofloxacin, or azithromycin. Now coming to the pharmacological therapy. So we have to initiate the therapy once the patient is brought to the hospital, right? So empiric therapy must be instituted promptly because the results from culture and sensitivity testing of CSF will not be available for more than 24 hours. The regimen should take into consideration the patient's age and any predisposing conditions. Antimicrobial therapy should last at least 48 to 72 hours or until the diagnosis of the bacterial meningitis can be ruled out. Okay, so continued therapy should be based on the assessment of the clinical improvement and cultures and susceptibility testing results. So once the pathogen is identified, antibiotic therapy should be tailored to the specific pathogen. The first dose of antibiotic should not be withheld even when lumbar puncture is delayed or neuroimaging is being performed. While selecting the antibiotic, the fact that should take into consideration is that the antibiotics which is selected must penetrate adequately to cerebrospinal fluid. So, for understanding that, we have to look into blood-brain barrier and BCSF barrier. So, there are two distinct barriers that exist within the brain: blood brain barrier and the blood CSF barrier. In short, we can say BBB for blood brain barrier and BCSFB for blood CSF barrier. So in this figure you can see the normal tissue capillary. So in the normal tissue capillary there is penetration and pinocytic vesicle, then mitochondria, lipid soluble endothelial cell membrane, right? Whereas in case of blood brain barrier, you can see the capillaries of the brain tissue is specialized. Okay, so as in the normal tissue capillary, there also you can see mitochondria, pinocytic vesicles, penetration and all, but these cells are tightly closed and they are enveloped with the glial cells. You can see the glial cells around these endothelial cells. Okay, so here is the tight junction. So the blood brain barrier consists of these tightly enclosed capillary endothelial cells. So the drug entry into the once the drug enters into the capillary, it has to penetrate these tissues, endothelial tissue, then it has to further penetrate the glial cells. Okay, so this blood-brain barrier separates the blood from the interstitial fluid of the brain, and unlike the capillaries in other areas of the body, the capillary endothelium of the brain are packed closely together. So they forms these tight junctions and it acts as a barrier physiologically similar to the continuous lipid bilayer. Okay. So the surface area of this blood-brain barrier is more than 5,000 times greater than that of the blood CSF barrier. So this plays a more important role in protecting the brain as well as regulating its chemical composition. Now coming to the capillary of blood CSF barrier. So here you can see the specialized epithelium of the choroid plexus, and here you can see the CSF, then tight junction. Okay, so this BCSF barrier is morphologically characterized by porous capillaries. So this porous capillaries allows proteins and other molecules including antibiotics to penetrate freely into the interstitial space. Okay, so here we have discussed that there is a specialized epithelium in the choroid plexus, right? So these cells are called ependymal cells, and the diffusion of the substance from the capillary into the CSF is restricted with the tightly closed ependymal cells. Okay, so this function as an active transport system similar to the renal tubular epithelial cells. So these ependymal cells are present on the ventricular side of the choroid plexus. So now you have the idea how the capillaries look at the blood brain barrier and the blood CSF barrier. Okay, so the entry of the antimicrobials into the CSF, that is the ability of the antimicrobials to penetrate into CSF, depends upon antimicrobials, lipid solubility, degree of ionization, molecular weight, its protein binding and susceptibility to active transport systems operative within the choroid plexus. Now let us see the penetration of antimicrobial agents to CSF. So here you can see three types. So this indicates very good and moderate penetration of drugs into CSF. First one is the therapeutic levels in CSF with or without inflammation. So there are a variety of drugs. You can read sulfonamides, chloramphenicol, rifampin, ethionamide, metronidazole, trimethoprim, isoniazid, pyrazinamide, cycloserine. So these drugs have especially metronidazole, sulfamethoxazole and trimethoprim. They are very small and they have highly lipophilic nature and they penetrate easily into the cerebrospinal fluid and achieves adequate concentration even when the meningeal inflammation is absent. So when there is a meningeal inflammation, the drugs can easily pass into the CSF. Why? Because the tight junctions between the endothelial cells becomes leaked, right? It loses the tight junctions, so it can easily leak into the CSF. Among these, rifampin, it is again lipophilic in nature. They have a high degree of protein binding and it achieves satisfactory CSF penetration. Now second one is the therapeutic levels in CSF with inflammation of meninges. Here you can see a lot of drugs such as penicillin G, carbanicillin, nafcillin, piperacillin, cefotaxime, etc. So among these beta-lactams, they penetrate poorly when the meninges are intact. But when the meninges are inflamed, most penicillins and third and fourth generation cephalosporins, they achieve CSF concentration sufficient to treat the meningitis. So the ceftriaxone, it achieves bactericidal activity within the CSF and they are having a highly protein binding nature. Now vancomycin, it have large hydrophilic compound with moderate protein binding. As such, does not diffuse well across the blood CSF barrier, but its therapeutic concentration in the CSF may be attained with systemic vancomycin therapy when the meninges are inflamed. Now, fluoroquinolones, they are moderately lipophilic and have molecular weight of approximately 300 Dalton. So they are not protein bound to a large extent as would be expected. They penetrate reasonably well into the CSF on a percentage basis. Whereas linezolid, which is having a bacteriostatic nature, so it achieves the CSF levels comparable to those in plasma. Now the third one is the non-therapeutic levels in CSF with or without inflammation. So there are drugs like aminoglycosides, cefoperazone, clindamycin, etc. Okay. So aminoglycosides, they have low therapeutic index and with IV dosing, it's difficult to achieve the adequate CSF concentration. And there is chance of toxicity when they are given through the intravenous route. So intrathecal administration is preferred. And this first generation and second generation cephalosporins, they are generally not recommended in the treatment of meningitis due to inadequate penetration and or its inferior efficacy. So this was about the penetration of antimicrobials into the CSF. Now coming to the empirical therapy. While discussing the etiologic agents, we have been seeing the organisms. Again, depending upon the organisms and age, we are providing the empirical therapy. So for infants who are less than 1 month, we can provide ampicillin and cefotaxime or ampicillin and aminoglycoside. And in less than 1 month neonates, and 1 to 23 months are infants, right? So they can be treated with vancomycin and third generation cephalosporin such as cefotaxime or ceftriaxone. And in the younger adults, that is 2 to 50 years, we can treat with vancomycin, third generation cephalosporin such as cefotaxime or ceftriaxone. And in the older adults, those who are above 50 years, we can treat with the help of vancomycin, ampicillin and third generation cephalosporin such as cefotaxime or ceftriaxone. So depending upon the age and the possible organisms, we are providing the antimicrobial therapy to the patient. Okay. Now let us see the antimicrobials for the treatment of meningitis in detail. So once the pathogens are ruled out, we have to tailor the antibiotic treatment, right? So here you can see the gram-positive organisms. Gram-positive organisms such as Streptococcus pneumoniae. So here the treatment is based upon the gram-positive organism and gram-negative organism. So first of all, let us see the first choice of antibiotics for gram-positive organism. Here this Streptococcus pneumoniae, they have 3 strains: penicillin susceptible, penicillin resistant and ceftriaxone resistant. Depending upon that, we have to select the antibiotics of first choice. So if the Streptococcus pneumoniae strains are penicillin susceptible, we can treat with penicillin G or ampicillin. And if they are penicillin resistant, we can treat with vancomycin plus cefotaxime or ceftriaxone. And again, if they are ceftriaxone resistant, we can treat with vancomycin plus cefotaxime or ceftriaxone. And there is alternative antibiotics also. So if antibiotics of first choice are not effective, we can select the alternative antibiotics. Then coming to the next one, Staphylococcus aureus. So if they are methicillin susceptible, we can treat with nafcillin or oxacillin. And in case of methicillin resistant Staphylococcus aureus, we can treat with vancomycin. So while treating the Streptococcus pneumonia strains, we have to treat for 10 to 14 days. Okay, 10 to 14 days. Then for Staphylococcus aureus, the duration of therapy is 14 to 21 days. Now for group B Streptococcus organisms, we can treat with penicillin G or ampicillin plus or minus gentamicin. And the duration is 14 to 21 days again. And now coming to the Staphylococcus epidermidis. For this organism, we can treat with vancomycin and the duration is for 14 to 21 days. And for Listeria monocytogenes, penicillin G or ampicillin plus or minus gentamicin are administered for more than or equal to 21 days. So when the patients are getting infected with Listeria monocytogenes, we have to treat for approximately 21 days or more than that, depending upon patient's survival. So gram-negative organisms, among that Neisseria meningitis, if the strains are penicillin susceptible, we can treat with penicillin G or ampicillin. And if they are penicillin resistant, we can treat with cefotaxime or ceftriaxone. And the duration of therapy should be 7 to 10 days. And in case of the gram-negative organism Haemophilus influenzae, if they are beta-lactamase negative, treat with ampicillin. And if they are beta-lactamase positive, we can treat with cefotaxime or ceftriaxone, and the duration is 7 to 10 days. And for Enterobacteriaceae, the possible first line is cefotaxime or ceftriaxone for 21 days. And Pseudomonas aeruginosa can be treated with cefepime or ceftazidime plus or minus tobramycin for 21 days. Okay. So here you can see almost all the organisms are covered, and there are the first line of treatment, and duration is lengthy for infection with Listeria monocytogenes, that is for more than or equal to 21 days. Now coming to the dexamethasone as an adjunctive treatment for meningitis. In addition to antibiotics, dexamethasone is a commonly used therapy for the treatment of pediatric meningitis. So, at present, this adjunctive dexamethasone therapy is used in infants and children with infections of Haemophilus influenza meningitis. Okay, so the recommended IV dose is 0.15 milligram per kg every 6 hours for 2 to 4 days, initiated 10 to 20 minutes prior to or concomitant with the antimicrobials. Okay, but not after the first dose of antimicrobials. And if the dexamethasone can reduce, so why we are using dexamethasone as an adjunctive treatment? So this dexamethasone can reduce cerebral edema and it helps to lower the intracranial pressure. In addition, these corticosteroids reduce the synthesis and the release of pro-inflammatory cytokines such as TNF alpha, interleukin beta and all. So these two cytokines play a role in initiating the cascade of events that leads to neuronal tissue damage and neurologic sequelae and all. So this dexamethasone inhibit this synthesis of this pro-inflammatory cytokines. So the clinical outcome is unlikely to improve if the dexamethasone is given after the first dose of antimicrobial and should therefore be avoided. If adjunctive dexamethasone is used, careful